Now the odds ratio was given, confidence limits are given. What does odds ratio will tell you? First of all, how do you calculate odds ratio? With risk factor, how many have disease? Without risk factor, how many have disease? And based on that, you will calculate the risk ratio, relative risk. Okay? Suppose if the odds ratio is 0.6, what does it mean? If this risk factor is there, I have 6 times more chances of developing a particular disease if this risk factor is there, if the odds ratio is 6. Okay? So that's how we, there is 6 times more chances for me to develop a disease compared to the person who don't have the risk factor. So it is the risk ratio which is being calculated. Now the question comes, how do you interpret a confidence limit? What is the meaning of it? What do you mean by confidence limit? When we say 95% confidence limit, the meaning of that is, if this particular risk factor exists with this particular value, there is a chance on long run that the association remains consistent. 95% confidence interval does not mean there is a 95% chances of getting a disease with a risk factor. It is not the meaning of it. The meaning of it is, if this particular value of the relative risk which you calculated by the odds ratio falls within this range, then there is a great chance, a consistent chance that the disease exists. You are able to get me? Now what were the various 95% confidence limits for the risk factor A? The value should fall between 1.1 to 3.1. But actually patient's value is how much odds ratio calculated? 3. So 3 is falling between the two. That means it has an association, strong association. Then risk factor B is 2, but its confidence limit 95% is 1.1 to 2. That means it is also falling within that range. That means it is also qualified. It is like a pass or no pass, like a DNB result, not like an entrance exam. Even risk factor C, whose odds ratio is 1.0, confidence limit being 0.5 to 1, it also has got a 95% confidence. You can say there is an association. So we can say that all the risk factors A, B, C are equally associated with that particular disease is what you can be able to say based on these presumptions. Okay? So the purpose of the confidence limit is to create a range of values rather than a single value. For you to draw the conclusions is what I want to underscore to all of you. Now let us go to the next question. In anesthesia, one question on local anesthetic, one on muscle relaxant, a little bit about general anesthesia, regional anesthesia and their complications. Over. So in local anesthesia, what is the general favorite question of the examiner? We have reviewed one of the Sundays, one-day anesthesia review. What is that? What are amides, what are esters? If you know that, you know local anesthesia. There is not much to read about it. Which will cause histamine release and lead to development of anaphylactic reactions, which do not. If you know that, you know local anesthesia. A much cheaper question than that is, which is the first local anesthetic discovered? So it is a knowledge on history. National Geography channel viewing is required for cracking the entrance. You must give a interview in the tomorrow after you become a topper. How did you got the seat, sir? No, I did not do much. I just sat and had a relaxed view of the TV. And to crack AIIMS November, you should read newspaper also. Why? Nobel Prize recently was given for which discovery was the question. So finally it is a Bournvita quiz contest. It has very little to do with your MBBS academics, etc., etc. So that is the reason you should be sure, doctor, it is the cocaine which is the one which is the first local anesthetic which is being used. Now anti-TNF alpha, before you use it, what precautions you should take? Fundamentally, what is anti-TNF alpha doing in rheumatoid arthritis? It is going and binding with the receptor of the TNF and preventing TNF, which is an inflammatory mediator, from destroying the tissues. That's how it is acting, right? By that it is causing an immunocompromised state to the patient. Already if there is a HIV which is uncontrolled and he is already immunocompromised, that stands as a contraindication for the usage of the anti-TNF alpha like infliximab, etc., is what need to be basically remembered. So there's a reason the answer becomes rheumatoid arthritis with HIV becomes an important contraindication. What maintains the stability of the alveoli? You all agree with me. It is a surfactant which will reduce the surface tension, which is important for maintaining the stability of the alveoli. Now for the elevated mood, what is required? You have to press on your carotids. Why? Vagal stimulation is known to elevate the mood, but don't do that. If you do that excessively, you may end up in a cardiac arrest, vasovagal syncope. But where did we discuss in the Sunday discussion, one psychiatry revision session? We discussed one topic called seasonal affective disorders. Those people who attended, if you remember, there we discussed about one of the past AIIMS question. Phototherapy is used to elevate the mood. Vagal stimulation is used to elevate the mood. So even this is an old question only. A little modified form of an old question is what I like to tell you. So it is the vagus nerve stimulation which is a very important adjunctive in managing the depression disorders, seasonal affective disorders, etc., is what need to be remembered. Now the dermatology. Highest number of questions come from which topic, doctor? The itchy lesions of dermatophyte. Tinea is a favorite question. So if you see this question, a boggy swelling on the scalp, easily pluckable hair. Don't use your brain also. Your cauda equina should pick up answer as KOH is the answer. Standard question, very standard question this is. Then leprosy. Without a question on leprosy, tuberculosis, SPM is is incomplete. There are nearly 22 questions asked in the past 15 years in AIIMS PGI and all India, which I'm also leaving high yield scanner page references. So you can review what are all the questions asked on leprosy. But examiner asks a very simple question. For a leprosy control program, what is a goal? Definitely the goal will not be to increase the leprosy among the children. How can it be a goal? I wonder, is it a question in the real entrance? How many have really answered AIIMS? Was the same question? Huh? Oh, examiner will give the questions where he want to wake you up from the sleep. Leprosy should be promoted. Yes or no, answer it. So that he will check whether robot is answering, or is there any remote control agent you are answering, are you sleeping and answering, for that purposes. So remember, doctor, if you feel suddenly tense about the entrance exam, review this question. Okay, tomorrow's exam question may come, HIV should be encouraged. Abnormal sexual behavior must be appreciated and broadcasted. Maybe a question will be like that, option of the question. So that is what you should guess and go. So what is the goal of the National Leprosy Eradication Program, doctor? To decrease the prevalence of the leprosy to less than 1 per 10,000 population is the goal of the National Leprosy Eradication Program, is what need to be remembered. Apoptosis. If you take pathology, top 20 topics, apoptosis is a favorite topic. We discussed in a great detail. What are the Bax genes, bad genes, etc., pro-apoptotic and anti-apoptotic factors, if you can recall. About the apoptosis, this time the question is much simpler. It is the fibroblast derived growth factor is the one which will prevent the apoptosis from happening in the memory cells. But let me tell you, I am quite sure even a topper would have not answered it confidently. If at all he answered, it is only a guesswork. But apoptosis like topics all so molecular in their nature that you have to grossly imagine them, whole problem. Now thiazides, what is the important complication of thiazides or beta blockers for that matter, doctor? If you give thiazides, patient's BP will come down, systolic BP will wonderfully control, but the problem is impotence is one of the important complications of the thiazide. Hyperglycemia is another complication, hyperuricemia. So that's the reason you should be careful that a precipitation of gout can occur because of the hyperuricemia which is created by the thiazides is what I want to underscore to all of you. Now tumor markers, nearly 19 questions were there in pathology. It is one of the top 20 high yield topics in pathology. Hepatoblastoma, there is an elevation of alpha fetoprotein, there is no big deal about it. Even in non-seminomatous germ cell tumors also, alpha fetoprotein is typically elevated. Then high prolactin is associated with what? This is a good question. Tell me, doctor, if the prolactin is high, will the estrogen will be low or high? High prolactin will basically create an anovulatory state and that lead to development of a low estrogen, low testosterone. That is the reason impotence is one of the presenting feature of hyperprolactinemia if it is the males. Loss of libido is one of the presenting feature of hyperprolactinemia in the case of the males and also females. Now the question comes, there is no elevated estradiol, definitely no, it is low with high prolactin, low testosterone also, there is a decreased libido also. I wonder what was the option given about FSH. Anybody, is it the same question in the entrance? AIIMS. High FSH was given or low FSH was given? High was given. Basically, how does prolactin prevent ovulation? Prolactin acts on the pituitary. Once more, it won't have a direct influence on ovary. Through FSH only, by affecting the effects, the levels of FSH and LH only it will act. The only reason why high FSH can occur with high prolactin is, we can explain the other way around. When high prolactin causes low estrogen should then lead to high FSH. That could be the only thing. I am not quite sure what was there in the examiner's mind. But anyway, ovulation is one of the high yield topics is what need to be remembered. Now full thickness graft, partial thickness graft. Grafting is one of the favorite questions of the examiner. But the question asked is, from where do you get that harvesting tissue? In case of the full thickness graft, you should be quite sure. So please remember, doctor, it is the upper eyelid, nasolabial folds, preauricular and postauricular areas and supraclavicular fossa. They are the classical locations, pre and postauricular areas and supraclavicular fossa, the classical locations. You don't take a full thickness graft harvesting tissue from the axilla is what you should be able to basically remember. Now let us go to the next question. Without a question on leukemia, lymphoma, there is no paper. You all agree with me? One of the CD markers, without asking that, examiner won't leave you. So you have to remember all the CD markers of all the common hematological malignancies. Now this time what is the CD marker? Burkitt's leukemia. If you take Burkitt's leukemia, lymphoma, it will be CD19, CD20, CD10 positive, and IgM is the one which is positive on the mature B cell. Even that is also positive. That's the reason it will be surface Ig positive. But it will be CD34 negative is what need to be remembered in any exam. Now, a serum alkaline phosphatase which is low, where do you typically come across? Always the rule is, if the alkaline phosphatase is low, think of one common condition, very common condition for a low alkaline phosphatase. Hypophosphatemia. There is a primary hypophosphatemia is an entity in itself where kidney will be losing the phosphate into the urine and the phosphate levels will be low in the plasma. Hypophosphatemia is synonymous with low serum alkaline phosphatase. Can you give me one more situation where alkaline phosphatase will be typically low? Suppose if you have a nephrotic syndrome patient with albuminuria continuously, if you look at his LFT, you find a low alkaline phosphatase. So that is the reason you should remember, high alkaline phosphatase goes with hyperphosphatemia, low alkaline phosphatase goes with hypophosphatemia is what I like to underscore to all of you. Now I leave all that for your literature. Now the next question is from pemphigus vulgaris. If you can recall our recent dermatology session on the Sunday, the top 20 topics, bullous pemphigoid versus pemphigus vulgaris, without that there is no paper. Now tell me doctor, elderly people, what do you find? Bullous or pemphigus vulgaris? One loud confident answer. Bullous pemphigoid. Mucosal involvement is a feature of pemphigus vulgaris. Then which is subepidermal, which is intraepidermal, in which you find Nikolsky, where you don't find Nikolsky. These are all the favorite questions of the examiner. Once more, examiner did not use much creativity. He simply asked you a question, where do you find the immunoglobulin G in pemphigus vulgaris? You find the deposition of the immunoglobulin G between one cell and the other cell. Desmoglein antibodies they are called as. So it is fundamentally intraepidermal immunoglobulin G, not subepidermal, is what you have to basically remember in the case of the pemphigus vulgaris. Now to monitor syphilis, which is the best test? On any given day, it is the VDRL which will give you a very good indication in order to monitor. The titers of the VDRL should come down with a successful treatment is what need to be remembered. From where does the acoustic neuroma basically arise? It is the superior vestibular nerve, which is the most common site of origin. Once more, let me tell you doctor, in the top 20 topics, acoustic neuroma is a favorite topic in ENT. Without that there is no paper in ENT. So please, the same thing is repeated, acoustic neuroma, superior vestibular nerve. Now preterm labor is one of the top 20 high yield topics where nearly 16 questions came in the past 15 years. So in the heart disease you cannot use nifedipine, but max sulfate is absolutely safe in the case of the heart disease as a tocolytic agent is what need to be remembered. Now how much is the uterine blood flow? What is the high yield topic from where this question has come from? Physiological changes in pregnancy. There are nearly 15 questions which have been asked in the past 15 years. So don't miss this question doctor. The uterine blood flow will be around 700 ml per minute. That is, it will be more than 500 ml per minute becomes the answer, and it represents 10% of the cardiac output almost in case of the term pregnancy is what I want to underscore to all of you. Now once more the question is in the pathology about the CD marker, about the B cell. So you should remember that CD19, CD20, CD10, they are all the B cell markers, but not CD135. So tomorrow's exam he may ask you what is importance of CD135. So CD135 is typically found in the hematopoietic progenitor cells is what need to be remembered. And what is the importance of CD135? Typically in the acute myelogenous leukemia, presence of a mutant form of the CD135 is a marker of poor prognosis. So that is the importance of CD135. It is not a B cell marker, it is a progenitor marker. Undifferentiated progenitor cell will be there, no? Totipotent cell. Before becoming T or B cell, it is a marker of the progenitor cell is CD135 is what need to be basically remembered. Now once more a question is about the CD markers only. So 3 CD markers in AIIMS entrance is like 3 times nailing the coffin. So you have never read this topic of CD markers, or you read but forgotten about it. Naturally it is very common to forget it. Then no one can help that presenile Alzheimer's which you are suffering from. Anyone will suffer from. So please remember that if you take the B cell lymphoma, if you take Burkitt's lymphoma, how will be the CD denomination of Burkitt's lymphoma doctor? CD20 positive, 10 positive, BCL6 positive but BCL2 negative, and TDT is also negative in case of the Burkitt's is what need to be remembered. And if you take the BCL2, it is a very important precursor of the group called mantle cell lymphomas. they will all be BCl2 positive, typically is what need to be remembered. But if you take the CD10, CD10 is not positive in case of mantle cell lymphoma. It is the BCl2 which will be found in mantle cell lymphoma. Then what is the importance of CD10, doctor? Typically CD10 is a very important marker of the Kala antigen. Kala stands for common acute lymphocytic leukemia antigen, it is called as. That is CD10 basically. So it has nothing to do with the mantle cell lymphoma is what you have to basically remember. Now once more, if you take pathology, top 20 topics, P53 is a commonly asked topic. Now this time the question is very simple. You don't need to even use the brain also. Will P53 mutate to form childhood neoplasm or it won't mutate? It is a mutation of the tumor suppressor gene called P53 lead to malignancy, not a non-mutation. It is once more a question. What was the earlier question we had? Purpose of National Leprosy Program is to increase prevalence. So once more, second time he is waking you up with the 50th question. So let us go to the next topic. Hirschsprung's disease is what? Very fundamental question asked. Earlier there are about 15 questions about Hirschsprung's disease which are there in the topic scanner. So please remember that it is the absence and migration, absence of the migration of the neural crest cells from the cranial to the caudal direction is the one which is responsible. They are unable to migrate caudally. The underlying cause of the Hirschsprung's disease is what need to be remembered. If there is a blunt injury abdomen, it is a straight repeat question. In a hemodynamically stable individual, what is the best investigation you want to do? You don't need to do a diagnostic peritoneal lavage. It is a very insensitive way to do that. The person may go and file a human rights case against you if you do a DPL unnecessarily in a hemodynamically stable person. FAST. What does FAST stand for, doctor? Focused abdominal sonography for trauma is called as FAST. And it is the FAST. What are the 6 important recesses you will be checking quickly through a ultrasound probe in case of the technique called FAST? You will be checking the splenorenal recess, hepatorenal recess, pericardiac space, right paracolic gutter, left paracolic gutter and the cul-de-sac. Quickly you will check all the 6 locations. If there is no fluid there, then you can assure the patient that intraperitoneally there is no injury in a case of the blunt trauma abdomen. In a hemodynamically stable patient is what need to be basically remembered. Now nasopharyngeal carcinoma. What is the best treatment that you want to offer? Radiotherapy any given day. It is once more a very high yield topic in the ENT, top 20 topics only. It is not a rare topic asked in ENT. So you should be quite sure when do you call, what do you call T3N1 M0 as stage 3? And if it is stage 3, what is the best treatment? Chemoradiation and high dose of superfractionated radiation therapy is considered to be the management of choice in case of the nasopharyngeal carcinoma, which is in stage 3 is what need to be remembered. Now which neural tube defect has got a high association with chromosomal abnormalities? Once more, neural tube defect is one of the top 20 topics in gynecology obstetrics. Nearly 15 questions came on this. So you should remember that it is the omphalocele which has got a very high association with the chromosomal abnormalities is what you have to basically remember. Now without a question on subarachnoid hemorrhage or intradural or subdural and extradural hemorrhage, there is no question paper at all. So the same thing, a sudden thunderclap headache with a ipsilateral dilated pupil is because of a aneurysmal rupture leading to the development of the intracranial hemorrhage is what need to be remembered. Now malaria, once more you are 10+2 knowledge. You don't need to prepare for MD entrance specially. You should not lose the knowledge which you got in 10+2. Now the question is very simple. What is infective stage to mosquito, not to human being? So it is the gametocytes which are eaten by the mosquito and mosquito becomes pregnant. So that is what you have to remember. It is the gametocytes which are infective, not the vice versa, not sporozoites, not trophozoites. So no big deal to crack the exam. Now, Clostridia is a very favorite topic of the examiner. You should remember that if you take Clostridia, it is not the hyaluronidase which is the most important toxin. What is the most important toxin responsible for the Naegele's reaction? Lecithinase is the most important toxin. So I leave to you the literature of beta toxin, alpha toxin, epsilon toxin, what are they, which is more lethal, everything in the literature, kindly review that. To a premature baby, 32 weeks, emergency cesarean, develops respiratory distress. First of all, what is your diagnosis? First, what are the three differential diagnoses that will come to your mind, doctor? Hyaline membrane disease, transient tachypnea of the newborn, meconium aspiration syndrome, any of them. But when do you suspect transient tachypnea of the newborn? A full-term baby delivered by cesarean, you think of that. But a 32-week preterm baby delivered, you think of hyaline membrane disease. Now the question comes, how do you manage the hyaline membrane disease with such a severe respiratory distress? We have to give oxygen, CPAP is given, and an exogenous surfactant administration is another important part of the treatment. You can also subject the baby to the ECMO, which is extracorporeal membrane oxygenation. There are the various modalities by which you basically ventilate the baby is what need to be remembered. Now, coactation of aorta. There are nearly around 12 questions which came in cardiology. It is one of the top 30 topics we can say in the cardiology. Inevitably one question comes generally. So you should remember, there are two types of coactation of aorta. What are they? Preductal versus postductal, right? Where the ductus arteriosus connects aorta with pulmonary artery. So the narrowing of the coactation can be preductal or it can be postductal. Tell me one single difference between preductal and postductal coactation of aorta, doctor. If you take the preductal coactation of aorta, the collateral circulation will develop poorly in the intrauterine life. Why? Because in intrauterine life, ductus arteriosus naturally is open and it maintains the circulation. If the coactation is proximal to the ductus arteriosus, no one bothers. So it won't develop. Collateral circulation won't develop in utero life if it is preductal coactation, right? But if it is a postductal coactation, right? In the embryonic life, what will happen? Normally, how is the circulation? Right ventricle pumps the blood into the pulmonary artery. From pulmonary artery through the ductus arteriosus, it enters into the aorta and it flows. That is a normal thing in case of in utero life. So if this coactation is distal to that ductus, then in intrauterine life only the collaterals will start developing. So that is the fundamental difference between the two. Now the question comes, what is the source of collaterals? How will it bypass that coactation and still be able to supply the lower part of the body, the blood supply? The collaterals are provided by the subclavian arteries, scapular artery, internal thoracic artery and the intercostal artery are the contributors for the collaterals is what need to be remembered. There is no contribution coming from the vertebral artery, which becomes the answer. Now let's go to the next question. In ileocecal TB, what kind of anemia do you find? Ileum is important for vitamin B12, so megaloblastic anemia is the one which you basically come across. Now with the Valsalva maneuver, which murmur become increased? This we have discussed n number of times. We have tired in discussing this. So it is once more a favorite question of the examiner. Now tell me, doctor, why will Valsalva maneuver increase the murmur in HOCM? Very simple. First of all, why there is a murmur in HOCM, a systolic murmur in HOCM? This hypertrophied interventricular septum at the time of ventricular systole will move and obstruct the left ventricular outflow tract into the aorta. Okay? The hypertrophied interventricular septum. Now what will make this obstruction more? If the left ventricular chamber size is small. See, suppose in a hostel we are two classmates staying in the same room, do we fight? Yes. Once in 15 days. So we got another couple of hostel roommates. Then what will happen? We fight more commonly because somebody wanted to switch on the radio, somebody wanted to put off the television, etc., etc. There are too many issues. So basically this hypertrophied septum which is inclining into the left ventricle, causing an obstruction to the outflow, will be more if the left ventricular size is small, if the hostel room is smaller. So what happens with the Valsalva maneuver? With the Valsalva maneuver, basically, the amount of the preload reaching the heart will come down with the standing and Valsalva maneuver, etc., etc. So that makes the chamber size to become smaller, and a decreased chamber size will cause increased crowding and make the systolic murmur to become increased, is what need to be remembered, right? But what happens with the Valsalva maneuver or standing in other heart disorders? If the blood flow to the heart is decreased, then all the murmurs will decrease naturally. Only when there is a traffic, there is a sound. There is no traffic, no sound. So standing Valsalva, decreased venous return to the heart and decreased preload to the heart, decreased blood to the heart will decrease the murmur in all other heart disorders. But the only condition where the heart murmur will increase in intensity will be in the HOCM, is what you have to basically remember. Now haptoglobin is very important marker. Marker of what? Intravascular hemolysis. It is a very important marker. But it is difficult to interpret the haptoglobin values in pregnancy. Why? Because pregnancy is a state of hemodilution, and that can lead to a low haptoglobin naturally, even without intravascular hemolysis only, and that can interfere with your interpretation, is what you have to basically remember. So the low serum haptoglobin in hemolysis is masked by the pregnancy, is what need to be remembered. Now in vaginous granulomatosis, what is the most common renal lesion? This is a very good question. How many would like to answer it as interstitial granuloma? Because vaginal is a granuloma everywhere. But that is not the answer. It definitely causes interstitial granuloma, but the most common classical pathological lesion caused in the kidney by the vaginal would be undoubtedly the focal necrotizing glomerulonephritis is the lesion which you come across with the vaginous granulomatosis. You can see that there are typical focal segmental glomerulonephritic necrotic changes in case of the vaginous granulomatosis, which is a very important classical feature, is what need to be remembered. Now you don't need to check for the ABO compatibility in which situation? Plasma has ABO antigens. So fresh frozen plasma you are giving infusion, you have to check ABO incompatibility. Platelets express ABO. There's a reason platelet rich plasma or platelet concentrate also you have to do. Then what is cryoprecipitate? Basically, cryoprecipitate is a strong precipitate of factor 8 and von Willebrand factor and factor 13. So that is the reason you don't need to do the ABO compatibility testing if you are administering the cryoprecipitate, let us say, to a hemophilic patient, is what need to be basically remembered. Now let's take up the next question. What do you mean by Hatter's shake? If you look at the past 15 years of question papers, AIIMS All India PGI, around 12 times the questions came on mercury poisoning. I leave to you the reference numbers of the pages in high yield topic scanner. So you should remember that it is the hat making industry. People are subjected to mercury poisoning and they were shaking at the dining table. So hence it is called as Hatter's shake. The mercury poisoning is what need to be remembered. Now a patient in medical OPD has got an increased direct bilirubin to 50%. Then what is your diagnosis among this? It is a striptease. Very simple question this is. Simply examiner asking which is a conjugated hyperbilirubinemia among them. So rotary is the only conjugated, whereas Gilbert and hereditary glucuronide transferase deficiency like Crigler-Nasser, they are all basically not conjugated in nature, is what need to be remembered. Now tell me, doctor, how do you differentiate the Dubin-Johnson syndrome from that of the Rotor syndrome? Both of them will lead to conjugated. But a piggy liver is a feature of with a brown pigment in the liver cells is a feature of Dubin-Johnson, but not the rotor. That is the differential between the 1 and 2. Now, lot of questions have been asked about Helicobacter pylori. Can you tell me some of these common issues for the examiner? What is triple therapy? Will it cause lymphoma? Will it cause maltoma? Will it cause duodenal ulcer? Will it cause gastric ulcer? Everything. I think now you are all like the American Scud missiles, ready to attack the examination any moment of time. But the examiner asked a very simple question about Campylobacter this time. Do you see it only in humans, or where will you see it? Once more, Geography channel you must watch. National Geography channel you have to watch. So there are a wide range of species. Mammals, birds, your pet cat, your pet dog, anything can home it. Humans are not the only reservoir, is what you have to be very clear. Now, a young female with the weakness of the gaze, with the intermittent ptosis, with the proximal muscle weakness, with the fatigability, and what is your possible diagnosis, doctor? Myasthenia. Now the question is it hydrophonium test more sensitive, or is it the EMG? Hydrophonium is an outdated test. It is the EMG which will, it is the repeated stimulation you give with EMG, single nerve, and you will check for whether fatigability can be observed on the graph. So observing that fatigability on repeated single nerve stimulation is a wonderful EMG way of recognizing the myasthenia gravis, is what need to be basically remembered, which is the best investigation. Now once more in the ophthalm, the question is about the proptosis. A young female repeated pain on the medial canthus, and now she has intense chills, rigors, diplopia on lateral gaze, optic disc got congested. Then what is the likely diagnosis? Now what is a very important clue out of all these findings, doctor, to say that your diagnosis is orbital apex syndrome? Can anybody give a possible clue which is there, which will make me to answer it as orbital apex syndrome? It is the optic nerve involvement with the congestion of the optic disc and the pressure on the optic nerve. That only will occur with an orbital apex syndrome rather than the other three. Otherwise all the four are potential causes of proptosis, and they can be responsible for diplopia on lateral gaze. But it is only the orbital apex syndrome which is the one which is causing the compression on the optic nerve, which will be leading to the development of the congestion of the optic disc, is what you have to basically remember. Now a 7-year-old boy with a history of trauma 2 months back, and there is a laminated periosteal reaction. Can you give me another simple name for laminated periosteal reaction? Onion skinning. Very good. Now tell me, doctor, if you say onion skinning, immediately your answer will go towards Ewing's, and you wanted to do biopsy. But that is not the case here. Here he has got an high ESR, he has got a fever and an acute pain. They are all highly suggestive of a possibility of osteomyelitis, and that puts technetium scan as the best investigation, especially in the view of the background of trauma. We like to do a evaluation of the osteomyelitis with the technetium. That becomes our investigation of choice. Now phenytoin, if you look at the pharmacology top 20 topics, phenytoin is one of them. 11 questions are there which were asked about the phenytoin. So it shows a zero order kinetics classically. Tell me, doctor, what do you mean by zero order kinetics? What is the difference between first order kinetics and zero order kinetics? I'll give you one clue. In 1 hour 100 grams became 50. Next 1 hour it became 25. Next 1 hour it became 12.5. Next 1 hour it became 6.2. I mean 50% of that. This is basically called as first order or zero order. It is first order. That is, there is a constant time. In that time, fixed percentage of the drug is getting consumed. It is called as first order. Whereas in a given constant time, if a fixed amount of drug, not percentage of drug, right, then you call zero order. So if you look at the phenytoin, the elimination of phenytoin will follow a first order kinetics if it is low drug concentration of phenytoin, and if it is a high drug concentration, it follows a zero order kinetics. Now tell me, doctor, will a drug will be rid of from the body fastly if it is a first order or a zero order kinetics? First order, because after you get seat into MD, you will start forgetting the subject in a first order manner. Every day of your passing MD first year, you will be forgetting fixed proportion, so that you will become 0% knowledgeable by the end of 6 months after joining MD. But during preparation of 1 year, how will you follow? Zero order kinetics. A little every day, a little value, little number, not per proportion. So now the question comes. When you have a phenytoin toxicity, you want your body to eliminate the drug fast or slow? Fast. But first order is fast or zero order is fast? First order is fast. But first order occurs with low drug concentration, zero order occurs at high drug concentration, because the God did not study pharmacology topic, high yield topic, though it is phenytoin, and he created the human beings in a reverse manner, that in a high drug concentration it is zero and a low drug concentration is the first order. Even God can do mistake. We are after all mortals.